2 o'clock, and so we'll start on time. Welcome, everyone. So pleased that you've taken this time to join us and to join what I hope will be a informative discussion of a really common problem that most of us are going to deal with sooner or later, myself included. I think it's an important subject, and I think it's one that hopefully we can shed some light on. There's some new things happening with hearing aids, and it's important to be clear as we can about the problem and the solutions. So welcome. Glad to see everyone, and might have a couple of announcements toward the end. I think I'll save to them. But as usual, and most of you have been with us since some of these, as usual, we're having our two resident physicians, resident doctors who are here for a month of their training, presenting on this subject today. We have Dr. Alex Belote, who will start off, and Dr. Daniel Condi, that I'll tell you a little bit about both of them. So just as a reminder, they are in the 3 postgraduate years after receiving their medical degree. So this is an internal medicine residency training that they're doing with us, and we try to get every one of our residents. We have 33 or 34 residents at any one time, spread over those 3 years, and we try to get each of them out here for a month each year. We don't quite have enough slots to get everyone here, but hopefully that is going to change in the future so that we can. I want to thank you all and everyone who lives here for the welcoming. I think the thing I've heard consistently from our resident physicians is that they feel so welcome and appreciated, and that means a lot to me and a lot to them, I think. And I think it's proving to be a good partnership between Butterfield Trail and UAMS. We want to give good service. I think folks benefit from the service and from the convenience, and we're really happy to do that. In the meantime, you're part of a teaching and education process that really is important, and I think makes a big difference. So I've had good feedback from you, from people who live here, but I've had just as great a feedback from the residents that this is such a good experience. And I'd be real disappointed to hear anybody that didn't appreciate what a good experience it is. It's one of the first times they get a real practice, community-based practice experience to inform their habits and their growth professionally. So I mentioned Alex Belote, who's standing here ready to hit us for us to take off. So Alex is not too far from here. He grew up in Missouri, mostly in Springfield, Missouri. Went to college at Southwestern Baptist University in Bolivar. If any of you have ever been to Bolivar or to the trout hatchery and stream there, it's one of the fly fishing meccas in Missouri. And then he went to medical school in Mississippi. Interesting thing about Alex is he was obviously doing very well in college with his pre-med studies. We can see that on his transcripts when we interviewed him. But he's also spending a lot of his time playing tennis on a very good tennis team at Southwest Missouri, which I think you started every year. I remember a little bit from interviewing you. Made academic All-American twice as a tennis player, And one year while he was there, they played in the national championship game. As a tennis player, I'm really impressed with that. Really impressed with that. He doesn't get to play as much tennis now. Uh, but anyway, Alex is going to start us off and tell us all about hearing loss. So thank you for your attention.
I'll warn you all, I'm not nearly as good of a public speaker as Dr. Wright. But he mentioned one thing about this being a very common problem. And so I'm going to tell you just how common it is. It's the fourth most common disease of the elderly. Hearing loss is also the most common sensory impairment, and it can affect up to 47% of people over the age of 65. Right now, nowadays, over 5% of the world's population is experiencing some degree of hearing loss, and it's expected that by 2050, over 700 million people, or about 1 in every 10, will have hearing loss. And this number's projected to go up because of new technology, headphones, people listening to really loud music, unsafe practices like that. And why it's important to this audience is that of the people who experience hearing loss, 91% of those people are over the age of 50. So the obvious thing to go along with hearing loss is it's needed for daily life, communication, what I'm doing with you right now, sensory, being aware of our surroundings, and also safety things. You know, driving while being hearing impaired can be unsafe. Then there's some also not so obvious correlations. It's highly correlated with depression, decreased quality of life, poor memory, decreased executive function, and dementia. Loss of hearing can impact your ability to communicate well with others, leading to those social isolation problems sometimes in untreated cases. And Johns Hopkins study that I found in my research that looked at over 600 people over a couple decades, found that people with mild hearing loss had a doubled dementia risk, moderate hearing loss tripled their risk, and severe hearing impairment, people were 5 times as likely to develop dementia as well. And then on the bright side of that, therapy targeted to help hearing helps reverse a lot of those problems, especially the depression that I was talking about earlier. And so with that being said, be on the lookout for early signs of hearing loss, because the better we can treat it, the better you can get back to living your highest quality of life. Typical things that you wouldn't think about, if you're hearing well conversationally, but if you're out in public in a louder place and you're really struggling to catch other people's conversations, if you notice, especially nowadays, I'm not wearing a mask right now, but having trouble understanding people with a mask when you can't see their lips, that's another I spoke about earlier. Here's a picture of the anatomy of an ear. I'm going to walk the simple way through how our bodies perceive sound. Sound is carried throughout the air. It vibrates oxygen particles and whatnot in the air. And then that vibration of those particles goes into our outer ear, which is on the left side of this slide. It then gets transmitted through the middle ear, where the things like earwax exist, and then it hits our eardrum, the part in the middle labeled the tympanic membrane. The sound particles vibrate that, which then get transmitted to the 3 bones in the middle, the meatus, incus, and stapes. Those vibrate and then hit our vestibular and cochlear area, and those get transmitted into our brain, and our body uses nerves to perceive sound. And so hearing problems can arise from any of these areas. I'm going to kind of go through a few of the more common places we can lose our hearing, and then what we can do about them. If you've ever heard or know much about hearing loss, there's two main types. There's conductive hearing loss, and that mainly occurs in the outer and middle ear, where the physical part of hearing is occurring. And then there's sensorineural hearing loss, and that's more in the inner ear, where the nerves are then being transmitted into our brain. So like I was saying, there's the two types of hearing loss, and then there's some mixed. But hearing loss is usually not just one thing. It's likely multifactorial, age-related on top of other problems. But it can be from a variety of factors that you see up there. The nerve-related issues that I was talking about are on the left side. The number one up there is aging, and basically inside the inner ear up here, there's little hairs that help sense nerve sound, and over time those can be damaged. They don't really regenerate. Also, the nerves can break down over time. That's what causes the aging problem. Obviously, noise damage. It's not just loud music at concerts. It can be occupationally related. People who work with sandblasting, construction sites are really prone to it. Also, drug side effects. I was going to go through. They're rare, but it can happen. Older antibiotics were really notorious for it. Chemotherapy can sometimes cause it. Really high doses of aspirin can lead to it. And also, one that I was unaware of till I was preparing for this was erectile dysfunction medications such as Viagra. It can be a side effect. It's usually sudden onset within 24 hours of starting the medication. And then conductive causes, which, like I was telling you earlier, it's the outer ear and the middle ear where the sound is being transmitted physically into us. Can be really simple things such as fluid in our ears, either from infection or allergies. It can be foreign objects. That's more likely in kids when a bead or a toy or something gets lodged in there. But it can also be earwax. You'd be surprised how often someone's complaining of unilateral hearing loss, and then we take a look in their ear, and there's just a big plug of wax, and as soon as that's removed, there's improvement. And there can also be anatomical problems, like ruptured eardrum from infection, or sometimes flying an airplane can do it. The next thing I'm going to talk about is evaluation of hearing loss. This can be screened for by your physician, whoever that may be. It starts with a simple thing like a physical exam, like I was saying, looking in the ear, making sure there's no causes there, or infection. If those are negative, we can do a little a screening whisper test where we stand behind you, see if you can hear us whisper from either side. And there's also these special tests that I have labeled up there. It's kind of a complicated image, but basically we use a tuning fork. It looks a little silly, but we can put it in the middle of your head, And if the sound lateralizes to one side or the other, that means there's dysfunction in the equilibrium of your hearing. Basically, if you feel vibration in the middle of your head, you should hear it equally on both sides. But if there's a problem, it'll lateralize to one side. And depending on if it's in the outer ear or the middle ear versus the inner ear, it'll go to one side or the other based on the good ear. One of those tests is called the Weber test. The other is the Rhine test. The Rhine test, it's put behind your ear, and it's really easy to feel the vibration. We hold the tuning fork behind your ear, and as soon as you quit hearing it, we take it off, and then it's still vibrating out in the air, and you should be able to hear it again. If you can't, that means there's a problem with your sensory part of your hearing. We can also perform simple audiometry in the doctor's office. If any of you have ever had a Medicare wellness exam, that's part of that exam. This helps us determine if there's unilateral hearing loss, like these tests, but it also can pick up on bilateral hearing loss, which is the most common thing as we age. And then if you're experiencing hearing losses and we don't find anything in the office, we can refer you to an audiologist who is a specialist in hearing, the evaluation of hearing, and the treatment of it. And this is a complicated graph to basically show you the stages of hearing loss. So on the left side, we have hearing level, which is measured in decibels, if you guys have ever heard of that. For reference, normal whispers occur at 30 decibels. So if you look up there, if you're having problems hearing whispering, that means it's a mild case. And so if you follow that 30 over it, that hits up with mild hearing loss, that would be something, would be one of your first symptoms of hearing loss. Normal conversation or slightly amplified conversation like through speakers, that occurs more in the 60 decibel and plus range. And so that if you're having problems hearing the 60 decibels, that means your hearing's more severe. So if any of you have ever been referred to an audiologist and they tell you the decibel loss, that kind of gives you a little bit of a framework. That's what those numbers mean. The frequency is a little bit more confusing, and I won't get bogged down in the details of that. Then the last thing that I want to mention is tinnitus, or simply put, as you can see there, kind of the ringing, buzzing in your ear. It's sometimes normal. Normal would be the ringing in your ear occurring for less than 5 minutes at a time and only occurring about once a week. I know from my own personal experience it'll happen once in a while. It sometimes manifests in a different way, but typically it should be self-limited, a short course. If it's happening more often than that, then it would be considered pathologic and something you'd want to speak to your physician about. The workup of it is very similar to just hearing loss. We look for any causes. There could be foreign body earwax buildup, or it could be a side effect of medication that we need to look into. It can also be a sign of neurologic problems. So maybe we need to evaluate brain function, or it could be a sign of our blood vessels being having a noise called a bruit, which can be pathologic and something else we'd want to look into. Treatment is much more conservative than hearing loss. Typically, we don't do much for it unless it's really bothersome. But in some people, it can be really worrisome. Simple measures to help it would can include therapy. We can also stimulate background noise, similar to wearing or having a fan on when you sleep at night to kind of keep that background ringing at bay. And in really severe cases, especially the neurologic ones, we can do cochlear implants. Then we'll move on to more kind of treatment of hearing loss. I'll let my counterpart kind of start from there. Pardon the transition here.
Hi, folks. How are you doing? I'm Daniel Condi. I'll be talking to you about the treatments and where are some of the advances to help folks that have been suffering with hearing loss and where we're going. So first of all, I'd like to talk to you about removal of earwax. Remember how Dr. Belote said that there's basically 3 parts of the ear, and one of the first, let me remove my mask. Yeah, sorry about that. Got used to it. But removing of the earwax in the middle ear is something that we could do either in the clinic here at BTV or something that some folks do at home. It's effective for conductive hearing loss, and this could be done with either a syringe or a cerumen scoop or some form of suctioning. If it's a very impacted piece of wax, we could recommend using some water, about 5 to 10 drops, and letting it soak overnight for about 12 hours with some cotton in the ear, and then letting that kind of soften that earwax, and then using the scoop or the suction to remove that. There are some commercial preparations that people can use, and sometimes if you use this for more than 4 days, there's a risk of having an irritation in the ear canal, which we would advise to use maybe water first, go a little bit more of the conservative approach. Now for technologies, there you go, technology or devices. This is just a big overview of what are some of the hearing aids and some of the devices used for addressing hearing loss. There's the hearing assistive technology, there's the personal sound amplification products, over-the-counter hearing aids, which is something that's been approved now as of 2021, prescription hearing aids, implantable hearing devices, electronic acoustic stimulation, and cochlear implants. And the latter two are more effective in the sensory neural part, more in the nerve part of the hearing of the ear. So we'll address some of these devices due to time constraints. We won't be really diving into all of them. But the first one is a hearing assistive technology. Now this one is more of, this comes in a variety of either a pocket size, a personal amplification device, or even some telephone applications. We can use the telephone equipment amplification devices, which there's a lot of talk to text in your cell phone. That's one of the examples of this. Television listening devices, and even vibrating and flash devices for alarm clocks, smoke detectors, doorbells, anything where any person with some kind of deficiency in hearing could be reactive to that alarm or that device going off. So hearing aids, this is one of the best devices and one of the most digitally advanced technologies that's out there for helping address this issue of hearing loss. It's beneficial in both ears if we can tolerate that. So this technology has the greatest potential to improve the quality of life and also to help with hearing amplification. It's, like I said, for patients that have deficiencies in both ears, that's the best way to go. There's 2 types. There's an analog and a digital one. The digital one is a little bit smaller, more compact, more customizable, and it's overall a better experience for the patient. Analog is rarely used now. It's a larger device, and there's a lot more discomfort. There's a lot of large retail chains now that are able to sell some of these, such as Walmart and Costco, which usually sell some hearing aids at a more convenient price. But it's important to manage the realistic expectations of when you use a hearing aid. It's not like a contact lens that once you put it on, your vision returns to normal. This is more of, it helps improve depending on your deficiency, if you can go from a decibel loss of like 90 to maybe 60 or 60 to 30, which that's something to establish with the patients before we address this avenue of hearing aids. Again, best for mild and moderate levels of hearing loss, and prescription aids can usually cover some of this moderate to severe deficiencies. Over-the-counter hearing aids. Now, this is something new that in July of 2021, President Biden signed an executive order allowing the FDA to take over and kind of have a little bit more control on the quality of the product that is sold over the counter. This is, from what I understand, it's still under the review. It takes anywhere from 60 to 180 days since that signing. So this is going to the cost is going to decrease because of the availability of being over the counter. So something important to point out is that whenever a patient does decide to pursue this over-the-counter option, there is a lot of, you do have to fine-tune and make sure that it is the right device for your condition and for the level of hearing loss that you are experiencing. So it is positive that it is FDA regulated and it is sold directly to the consumer. You can buy it online through some vendors. And the technology, it is, depending on where you get it, the technology is comparable to the prescription hearing aid. There's a website down here which you can search if you do decide to follow up and do over-the-counter hearing aids recommended for FDA-approved devices from the National Institute of Deafness and Communicative Disorders. This will kind of give you folks a little list of the devices that are approved by the FDA. There's several styles of hearing aids. There's completely in the canal, which this helps address mild to moderate hearing loss. There's some that live in the canal, also for mild to moderate. In the ear, mild to severe. Behind the ear, mild to profound hearing loss, which is the most severe form of hearing loss. Body aid and bone conduction aid. Each has different advantages and disadvantages. The completely in the canal is one of the most common ones requested because of the cosmetic appeal, also because it is almost invisible. There's a less of occlusion of the overall ear, and it's also easier to use with telephone and if you have headphones. If you choose to wear headphones, it fits well with that. So all the patients don't qualify for different types. Again, based on your severity of deficiency is where your hearing aids would be most appealing for you. The canal is also cosmetically appealing, and it also has a telecoil available. And this, for the canal, it's also available for comfortable with hearing and with the headphones. There's some that are disadvantages, which can include the size. If it's way too small, it's a little bit harder to kind of manipulate and get, properly fitted. The battery life for some devices is a little bit low, so that could be a deficiency. But also just the dexterity overall and having the ability to learn the device and to be able to manipulate the technology that it's capable of doing. There are some open mold hearing aids which are popular for non-occlusive fitting, and this is good for patients with high frequency hearing loss. That's one of the best use for it, but also behind the ear, which is the behind the ear produces the greatest power. And this is a little difficult to insert, but it's also pretty good with headphones. And kind of moving on to the electronic capabilities. Overall, these hearing aids in the past, since 1996 is when they kind of started launching off, their technology has been improving tremendously. Some of these hearing aids have Bluetooth capabilities, noise canceling, wind canceling, and ability to even detect your environment around you and adjust your hearing aid to the sounds and what's going on around you, which is pretty impressive. There's also some that are specifically designed for high frequency loss. So, for example, if you can see right here on this picture, there's a gentleman with a clear tube that is going from the canal and extending up behind. That's very, very small. And this is one of the hearing aids that is for patients with high frequency loss. This is also a non-occlusive, and it's also a pretty convenient aid. It has a tiny piece of plastic that fits behind the ear in a thin, transparent plastic tubing that sits right in the ear canal. This produces less static than the conventional aid, which is also convenient and the patients find very enjoyable. There is, like I said, the research is advancing tremendously for this, and even some companies such as Bose is now in venturing into the hearing aid field. It is recommended for you to get a good fit, and preferably before you purchase any hearing aids, get tested by a licensed audiologist or come into the clinic and we can do a hearing exam, which we do with your annual Medicare wellness exam. Also, we'll check your ears out to see if there's any impaction of any wax or anything that we can address at that time. There is usually a 30-day fitting trial period, which doesn't include a minimal cost, if any, and that kind of lets the provider fine-tune the device, adjust it for any digital, any digital needs that it entails, and then you'll be rest assured that the device is to the best capacity for your hearing loss and how you will be able to benefit the most from that. So, barriers to using hearing aids. There's some people have complained, or some people have hearing aids but they don't use them. One of the most common barriers reported by the U.S. National Health and Nutrition Examination Survey found that 1 in 7 individuals 50 years or older with hearing loss use a hearing aid. Now, another review found that estimated 5 to 40% of the patients with hearing aids do not use them. So, just in perspective, about 40% of the people who have hearing aids don't use them. So that's kind of impressive. And we were wondering, what are some of the reasons for the lack of use? In older adults, it is found that social withdrawal could be a reason for people not to using the hearing aids. If you think you're not going to be going out much or you won't be talking to anybody, you probably won't be using your hearing aid. Lack of appreciation of hearing loss. Discomfort is also a main one. Lack of motivation. Inability to adapt to the new technology that the hearing aid provides. And just to kind of talk about another study, published in 2013, the Journal of Audiology reported that about 20% of adults between the ages of 55 and 74 found that they benefit from using a hearing aid, but they don't use one. So 20% of the people from that study found that they were to benefit from one, but they just simply choose not to use one. Hopefully, with over-the-counter hearing aids, this could be something that we could address a little bit more easily. Another method that we use is the bone conduction hearing device. Now, this is a device that transmits sound directly through the skull into the functional cochlea. This is an implantable device that the conduction hearing aid has better tolerated and improved sound quality. Previously, this was a very, very painful procedure. It would encompass the, extended hospital stay, a lot of pain for the patients. This bypasses the middle ear when the ear canal is unable to tolerate, when the patient isn't tolerating the ear aid or the mold of the ear. There's a deficiency there. The bone conductive hearing aid is also held against the skull previously with a steel headband, which was very painful. Now, the Baha, which is the bone anchoring hearing aid, is one of the most widely used implantable devices. There is some pain associated with this at the moment that you're going to get the device placed, but apart from that, once the device is fully functioning, there's minimal pain and there's very good results. You can see that there's an external device there on this gentleman's head. This has almost like there's a magnet that it's implanted. It's a microphone on the outside, and then that transits the information into the central cochlea, which processes the sound and the patient's able to hear. For this one, the Baha uses a small titanium implant, which osteo integrates into the bone of the skull, which causes a little bit of attachment to come up, and there's a magnet that it seeps down into, and that's usually it's better than what we were using previously. Now, cochlear implants. Has anybody heard of cochlear implants? I see a lot of people. So cochlear implants. So this is a very it's a good procedure. It's a surgical implanted prosthetic device that's used to provide electrical stimulation to provide hearing. Now, this bypasses the damaged or the absent cochlear cells, and that's how it directly goes and stimulates the auditory nerve. There are some criteria to be a candidate for cochlear implants. One of the criteria is to have moderate to severe sensory hearing loss, and patients who have been struggling to hear with an appropriately fitted hearing aid. Adults have been able to hear pretty well and been able to have good results within 4 to 8 weeks of placement of the implant. If you have bilateral sensory hearing loss, this is one of the devices that you could probably implant 2 of them and bilaterally, and the patients have been able to localize sound with moving their head coming in from both sides, and also they've been overall an improvement in the quality of life. So patients don't have to turn their head and you can detect sounds. Although it's usually you can use them for bilateral, you can also use it for unilateral, and also like Dr. Bullitt was saying, sometimes you can use cochlear implants for patients that have tinnitus. So there's a lot of ringing in the ears. One of the implications is that this requires extensive pre-implant testing, post-implant testing, and you would be under general anesthesia for this. Usually there's insurance companies cover this with prior authorization. And like I said, it improves the mood, the cognition, and the quality of life of the patient who receives this. Real quickly, this is kind of how this cochlear implant is going to work. There's a microphone placed right down there at the ear. The sound is going to be detected on the processor, and then it's going to be the electrical. It's going to be meeting at the transmitter on the external part, and then the sound wave is going to be transmitted via an electrical receptor implanted on the inside of the skull, which is going to send the electrical arrays down to the cochlear nerve. Once you see it down over here in that little circle, the cochlea, and that's going to stimulate the sound waves to activate the hair cells at the organ of Corti, and that's going to kind of transition from the electrical to the sound waves to work. It's an impressive surgery. Let me see if we can keep going. Some potential complications of this would be, the most common complication would be an infection, either from the surgery or a complication from an otitis media, which is a middle ear infection. Their general incidence of infections are occurring from 1.4 to 11.2%. It is recommended that patients who do undergo any cochlear implant or are in the process of getting worked up get vaccinated, specifically against your pneumococcus vaccine or against pneumococcus using the pneumococcus 13 and the 23, along with your seasonal influenza if it's available. Late complications of the implants include vestibular problems, about 3.9%, device failure in about 3.4%, and taste problems in 2.8%. Also, in some of the older devices, patients who have an older magnet in place, the use of MRI would be contraindicated because that can kind of rip the device up. So, but now with the newer devices, it is safe to use MRIs, and a CT scan is no problem. All right, folks, that was pretty quick. Now, thank you for your time, and just real quickly, hearing loss occurs commonly in older adults, and it could lead to a reduction in your quality of life, highly expensive medical costs, and it can cost your independence. There are many treatments available, so please follow up with your primary care provider so we can kind of do a routine screening and kind of get ahead of the curve, so to speak. Thank you so much, folks.
Thank you. Daniel, I forgot to actually introduce you. I didn't mention your name, but Dr. Condi's actually local. He grew up in Siloam Springs before he got away to Northern California for his education in Mexico. But we're glad to have him back in Arkansas. He does a great job. So you get a feel for the technology in these hearing aids. I was very disappointed, though, that they didn't, in the whole presentation, mention one of the things that's still available and still rates very high in terms of hearing amplification. And I think you may not believe me, but you can still, as of 8 or 10 years ago, the last time I checked, you can still get an ear horn. You can still get an ear horn. I saw it in an ENT catalog. I think I want one of those to hang on my wall. But it works. It's just for obvious reasons people kind of don't like to show their ear horn. And it's not as convenient. You heard them mention T-coil. I can't say that I shouldn't bring it up because I really can't explain the technology, but a lot of hearing aids, I bet folks in this room have a T-coil loop, an FM loop that in certain environments enhances amplification. And when I was first touring out here, before I started practicing out here, Quentin was telling me how the floor in the performance hall is laced with T-coil technology to enhance hearing aid reception. I thought that was pretty cool. So it's this is a subject that is so common and so important and influences our lifestyle so much. It's just impossible to ignore. It's so important. And yet, human nature is we don't shine to these hearing aids. I've told many of you, I started wearing hearing aids about a year ago, or right before COVID. And you know what? They worked a lot better before the masks. I said, is that the hearing aid or is that me reading lips? I'm not sure. But I'll tell you, one of the things he mentioned but didn't go into is the newer hearing aids. And I believe a lot of the less expensive ones that are going to be over the counter too, you can get Bluetooth technology. And I got that in mind. And I'll tell you what, I may not be 100% pleased with the hearing amplification all the time in every conversation, but anything that comes through my cell phone is crystal clear, perfect, because of the Bluetooth in the hearing aid. So that I can kind of recommend without fear of contradiction. And so if you've got music on your phone, or for every telephone call you get, you're not going to have trouble with that conversation or with that reception. I wish it did that as well with every conversation I have, but if it's through the phone, it really does. So, are there any questions for these guys? Yes. Logan's our fourth-year medical student, spending some time with us. He's glad not to have to speak today. He's handing off the microphone.
Okay. I wasn't real clear. I have ringing in my ears almost daily. Does that mean I need to come in for a test?
And I'm sorry, your question?
Do I need to come in for a test? Because it's almost daily.
Oh, yeah.
Can you hear me? Okay. So
The question was?
the question was, you're having ringing in your ears daily. My question would be, how long is it lasting for? Hours. Okay. I think it would be, do you wear hearing aids or anything? I think it would be worth getting your hearing checked to make sure, because like I was saying, pathologic ringing in your ears is anything over 5 minutes occurring more than once a week. It's, again, I did caution that there's not much we do about it unless there's a reversible cause, but we might be able to find one of those reversible causes if you're worried about it.
Yeah, tinnitus or tinnitus, whichever way you want to pronounce it, or ringing in the ears, is a pretty discouraging thing if you have it all the time. Fortunately, it's very rare to have really loud tinnitus all the time. Most people have it intermittently, and most people have it mildly, and after they've had it for a while, they acclimate to it, thank goodness, because I don't know anything we can really do about it, although there are some hearing aid devices that help cancel it out, but I think that's pretty imperfect. It's helpful, but not certainly doesn't eliminate it. So the lady here, and then we'll.
Why are hearing aids so expensive? I mean, you can get glasses for $100 and hearing aids are thousands.
Now
and
this is a
thousands.
medical talk. This isn't an economics talk. I can't say why, because a lot of these less expensive hearing aids that you're seeing advertised on TV, I think are pretty close to the ones I'm wearing. You know, I think it's always been a matter of you know, what the market will bear, and you know, you've got a medical community which sincerely, these guys are very sincere, I am too, I promise you, sincerely believe that people ought to do what they can and take advantage of the technology, and then the technology we point you to has historically only been available, not covered by Medicare, and too expensive for most people. I can't explain it. I think it's probably hard to justify. So don't have a good answer, but I kind of agree with your displeasure about it. Let's see. There was okay, right after this, we'll.
There were a number of people who raised their hands when you talked about the cochlear implant surgery. I wondered if they could tell us if it really helped them. Because we don't really know when we talk to somebody and they want to do it, what's the history of it?
I think they were raising their hands that they had heard about it, not that they have it. Does anyone have it that is willing to share cochlear implant experience? I will tell you that people who really believe, I'm talking about doctors who really believe in cochlear implants, I mean, not that there's anything not to believe in, but people who are most enthusiastic about it will tell you that it's best prescribed or indicated for the person with the worst hearing loss. So people who are profoundly deaf sometimes, often, usually have just dramatic hearing improvement with this. You can tell from everything Dr. Condi said that it's more involved. There's a lot more testing beforehand and afterwards. And there's an adjustment period. And that adjustment period, the one person I got to know who was a patient that, you know, most patients I've met who have cochlear implants are pleased with them ultimately, but they'll tell you that there is a period of adjustment. He said mechanical. Some people will say it has a harsh tone at first. This one woman just told me over and over again, every time I saw her, she said, it's really important to work with that. Everybody who does this, every physician's office who does cochlear implants also have an auditory rehab specialist who works with you afterwards, and that what they do, and I couldn't describe what that involves, but what they do really apparently makes all the difference in a person adjusting to it, and ultimately people seem to be very pleased with these. It's a 180 in terms of hearing when it happens. Was there anybody that's had personal experience with cochlear implants in your family, or no? No, but you have a question and you've waited patiently.
This, again, it might be more of a social question than a medical one. But like in healthcare, I think seniors do this more often than anybody. I've got this pill that really works for me, and maybe that's what you should have too. Now, I got today from Beltone a gift card for $850 for a new hearing aid. And now I would guess that that's going to be more than $1,000. And I think that that's where the confusion really comes in for those of us who are lay people. We really don't know which are most advantageous, although I think most of the hearing aid people give you a trial period. You give them a try, and if it doesn't work, well, we can go over. But getting suggestions from other people may or may not be helpful.
You know, one thing, I think that's true. One thing I became aware of a few years ago, I don't know whether it's still the case, but there are some who, rather than the trial period afterwards, their pitch anyway is free hearing test on the front end as kind of a case finding sort of. Now maybe they also have the free or the return, 30-day return, but I thought that was kind of misleading because it's I don't think many people who have enough hearing concern to come in to be checked are going to pass that test done by the one who will benefit from selling it. So anyway. Are there questions for the experts here? These guys, not me. In case you have another one, I'll just make a few comments about another topic, and then we can, if you think of another question, we can engage them again in talking about hearing aids. But once again, I want to say, as I have many times before, to everyone who lives here, how pleased, impressed, and proud of everybody here at Butterfield, including the administration, certainly all of you who have lived here, and how well you've handled the pandemic. Obviously we've had cases. We've had cases recently. But the vaccination rate and the case incidents have been good because everybody has participated in a positive way. Now the big question that I expected to hear regularly the last couple of weeks, and you haven't disappointed, is what about the booster and when is it coming? And let me first of all say that everything I know, and I, as you can imagine, since I work for UAMS, I'm getting a steady stream of what the current thinking out of UAMS is, and the CDC and the Arkansas Health Department, and continue to find all the real experts, the people I would point to and recognize as experts, believing that it's going to be important for everyone to take it at the right time. And the only thing that seems to still be to be decided, but probably pretty quick, is when. And you've heard 8 months after your second dose of whichever one you took. I know that most people here took Moderna, and so the plan would be, and I know Collier's is planning to come back. I'm sure that day hasn't been set yet when they're coming back, but they're coming back with a third dose of Moderna. And I would encourage everyone who's had the first 2 shots to take the third one. What I was hearing a few weeks ago, and I hadn't heard a change in this, that the studies on this third dose booster is that it's been consistently shown to increase your immunity and resistance to COVID by 9 to 10 times. That's pretty impressive. So again, thank you everyone for 99% of the folks that lived on this campus took the vaccine, and that's incredible. That's really exceptional. I think it's the most important reason. That and all the faithful mask wearing, I think's made all the difference. So pleased about all that. And you know, it's we even people who've taken, all of you, all of us, even those of us who've taken it, it's not that we didn't fear that we might have a reaction, but we feared more what was happening and what could happen worse from the pandemic. And you know, I've told some of you, my father was a small town family physician, and I remember in the late 50s when the I should be able to tell you the exact year, but when the polio vaccine came out, going with him around to smaller communities, giving the polio vaccine. And what I'm real clear on is you weren't having to persuade any parents to have their kids vaccinated, because they had seen polio and they'd heard about polio, and they knew what, you know, how scary that was. So, and COVID's scary too. I'll just tell you. If you get to talk to anyone who's worked in COVID units, you guys been right there. It is a scary, sad, devastating thing. I'll tell you on a personal note, my niece just graduated from nursing school in May, and her first job at Mercy, she was so glad to get this job on the cardiology floor. She's going to be a cardiology nurse. She's ready to go. And that unit got converted to a COVID unit before she set foot on it. Now she's a COVID nurse. And I said, you know, you'll be challenged throughout your career, and so get you ready for a lot of things. But she's already seen some heartbreaking cases. Yes, ma'am.
Space between the booster and the flu shot. What's a good space?
I think Carl Colliers is going to offer both the same day. That's what I've heard. I haven't heard anything about optimal spacing. Do y'all know?
Now, granted, throughout the course of the pandemic, everything's constantly changing. The last time, we get this question a lot, last time I checked the CDC recommendations, they were that you can receive them at the same time. Yeah. Yes. Moderna's currently applying for application of having a COVID immunization that is in conjunction with the flu shot. So you would get just one shot to get both vaccines.
Yeah. So you hadn't heard about any need for separation.
Correct.
Yeah.
Yes.
That's my understanding also. So that's a good thing. Yes, ma'am. I didn't know that. Because I think it will be October before probably the booster, and it's in these formal things like a day of the booster. I know it's not going to be. I think the very earliest I've heard about that has been September 20th. And I think most people out here, wasn't it February 8th or something like that for the second? So the idea would be October 8th. That's probably right. Yes, ma'am.
This may be my ignorance, but I've wondered, how do any of us sitting in here today know that we're not carrying it, spreading it?
I guess we don't know 100%, but it's kind of like the question of the person who's had a breakthrough illness, infection, you know, got vaccinated, and our standard recommendation is 10 days quarantine. but they're still coughing at 10 days. Should they be quarantined longer? And the CDC literature basically says in someone with an acute COVID illness, there's been no transmission after 10 days. In fact, almost all of it's much earlier than that. So you just simply shouldn't be contagious after 10 days.
But short of being tested daily, how do I know that I'm not sitting here spreading it? I don't, do I?
Right. I'll chime in.
Yeah.
You can't know, and so that's why we're wearing masks and trying to distance when possible.
Yeah.
Could you explain the new flu shot that we're getting? The difference in that and the old?
I haven't heard, I'm sorry to say. The question was about the flu shot this year. You know, every year it's a little different based on what they're mapping from Asia and moving eastward to the U.S. But I haven't heard. Have you heard anything?
No.
The email that we got from Patricia Portner, in bold print, it said it was a high potency flu shot. And I looked it up on the computer, and it said that it's different than the old flu shot. It has 4 antigens in it for people over 65 that the old flu shots didn't have.
Okay, there's probably particulars then that are different from before, but in format or in form, it's like the high potency that's recommended to those of us over 65 already. So,
Would the side effects be stronger?
not likely. That's not been the experience.
It sounds like it'd be very strong.
But I mean, it's partly based on the fact that as we're older, we don't respond as robustly in our immune response, you know, to the vaccines. And I would presume it'd be true of the reactions as well. Good question. Good question. We all kind of feeling our way through this. I'm sorry. We're here. Well, if there are no more questions, we've clearly opened it up to something outside of hearing loss. But if there are no further questions, I'll just thank you again for coming and for all your support of the clinic and the UAMS services out here. I so appreciate it. Thank you, thank you. Oh, I hope all of you saw the flyer on Dr. Swindell. So now we are open 5 days a week. So he's here every Tuesday. I haven't been here on Tuesdays anyway because I have administrative time I have to put in at UAMS. So now, even when I'm gone, we'll have Dr. Swindell and the residents here. Where I too get sick, he'll be available. So I feel a lot better knowing we've got that backup. Great guy, great guy. If you saw the flyer, I mentioned that we were classmates in medical school, and then we practiced together for about 8 years, way back in the 80s, and back when they used to call him Marcus Welby for good reasons. So thank you all.